Well, hello. I'm Naveen Pemmaraju, Associate Professor of Leukemia, MD Anderson Cancer Center in Houston, Texas, in the United States. And it's really my honor to spend a few moments with you thinking about and discussing an emerging important topic in our field of myelofibrosis, which is the main question of what does it mean to have disease modification in myelofibrosis, in MF, and how do we measure it? My goodness, this is a really important question, one that we have wrestled with and we will continue to in the coming years. So for historical background, myelofibrosis, or MF, is a potentially very deadly disease for many of our patients, with overall survival for some patients only measured in years rather than decades in the intermediate or higher risk settings. There's only one approved drug class that's known as JAK inhibitors, targeted therapy. And at the time of this recording, there are 3 approved JAK inhibitors with several others in late stage consideration. So you really have a potentially deadly disease with variable outcomes, only one class of targeted therapy agents approved, and the only curative modality so far has been that of allogeneic stem cell transplant. And so the question is, how do we measure and how do we modify the disease? Well, in terms of measuring the disease, we have the bone marrow biopsy that has been traditionally used. We have the blood counts, we have the spleen size, and we have the symptom burden, which was developed and pioneered by Dr. Ruben Mesa. And outside of these, oftentimes you have patients who may have discrepant findings, benefit in one area or domain and benefit in the other, but not all at the same time. So it's actually been a very difficult definition to try to get a hold of, a very elusive one. So now the reason why this is becoming important is now we are in the era of combination therapies. So that means you have a JAK inhibitor, the known traditional class, and now we're adding on a second agent or second class of drugs. And in this setting, we have many clinical trials, several of which are already in the phase 3 randomized setting, PI3 kinase inhibitors, BCL-XL inhibition with navitoclax, bromodomain BET inhibition with pelabresib. So now that we have combination therapies, we're moving beyond JAK inhibition monotherapy. Now we're in this new era with how do we measure the response criteria. And so some new elements have been put forward in addition to the standard ones. So in addition to seeing the blood counts improve, transfusions decrease, spleen size decrease, symptoms decrease, bone marrow blast decrease, can we add other factors? And so some of these newer agents are showing at a newer or deeper level disease modification. For example, in the navitoclax program, which I'm co-leading, we have shown that some patients can experience, in addition to those traditional factors, the addition of decrease in the VAF, variant allele fraction, decrease in the bone marrow fibrosis compartment, and even overall survival improvement in patients who experience one or both of those parameters. So it is among the first time that we're starting to see the correlation of the clinical factors and easily obtained lab factors, along with some of the newer generation tests. Of course, all of this still needs to be prospectively validated in future cohorts and larger numbers. In addition to that, a third compartment is arising, which is future considerations, which is, can we assess cytokine modulation at baseline and then over the course of treatment, and does that correlate with a disease response and assessment? And again, in the navitoclax, the bromodomain programs, and others, we're starting to see early signals that this may be possible. And then finally, can we build these into our prospective clinical trials so that we can actually, for the first time, measure this in real time? And again, a lot of these trials are doing that. The final component of this is, how do we all settle on this definition of disease modification? How many of these factors does it include? And that's an open question. My colleagues and I, led by myself and Professor Adam Mead in the UK, we recently published a nice little review article on this topic in Cancer earlier this year of 2022, starting to at least ask that question, to pose that question. What does disease modification mean? And of course, it involves a discussion of all of these factors. So in conclusion, I would say in 2022, the goal in MF therapy is to maximize the patient's quality of life, quantity of life, so overall survival, minimizing toxicities, and starting to modify the disease of the myelofibrosis in a deeper and more meaningful way, and then try to have a response measurement program that's consistent from patient to patient and that we can report and discuss with each other. Thank you very much for your time.